warm welcome to another show of President Meet President-Elect. And this is a show that is sponsored by Omnicurious Originals. And today it's a very beautiful talk show. It is something different from the regular webinars, which has your PowerPoint presentation. We've come up with this concept to ensure that it is going to be more of a very candid conversation with our who's who of the industry, especially the critical care medicine today. And today we have two stalwarts in the field of critical care medicine. And the talk for the next few minutes, I would say, is going to revolve around what are the essentials in critical care, how has the critical care field shaped up over time, and more so with the Indian Society of Critical Care Medicine. We have with us both the President and the President-elect of the Indian Society of Critical Care Medicine. And it gives me immense pleasure to welcome both the speakers today to our President Meets President-elect show. Thank you, doctors. Thank you so much for joining in.
Thank you. Thank you so much. Thanks for giving us the opportunity.
Right. So I think I forgot to introduce myself. I'm Dr. Pavitra Krishnan, and I would be also taking questions on behalf of the live Q&As that are going to be coming in from the younger doctors, the doctors who are from different specialities, because critical care medicine is like an interdisciplinary branch. It's not just one specific branch. We need a team to work together to see, a beneficial outcome. So we have a large audience who have joined in today. So I will also be taking the questions on their behalf and, sharing it with you to get your expert advice. So let's start off with a few things that we must know today. A little bit about the Indian Society of Critical Care Medicine. This was established in 19th October 1993 in Mumbai and is one of the largest non-profit association for Indian physicians, nurses, physiotherapists, and other allied healthcare professionals, which is involved in the care of critically ill patients. ISCCM, which was started with a small group of consultants, today comprises of more than 12,000 members and also is spread across 67 city branches across the country. Without further ado, I would like to first briefly introduce our speakers for the day. They are stalwarts in this field of critical care medicine. So I'm going to keep the introduction very, very brief so that we get ample time to discuss the burning issues and the things that our audience want both of you to address. We have with us Dr. Deepak Govil. Dr. Deepak Govil is the director of Medanta's Critical Care Unit and has been working in the field of critical care medicine for more than 25 years now. He's a teacher and is also an examiner for FNB, IDCCM and FICCM. He has contributed to several chapters, authored ICU guidelines and co-authored papers in national and international journals. He has actively participated in several international trials and studies, and Dr. Govil has also served as the Vice President of the ISCCM and the Vice Chancellor of the Indian College of Critical Care Medicine. He has many publications in both national and international journals. I'm not going to go into the details because his resume is fairly long. He's done a lot. He's got a lot of achievements to his name. So I'm going to stop at that and we're going to discuss during the chat show today. We also have with us another stalwart in the field of critical care medicine, a very known figure, Dr. Dhruva Chaudhary, who's a senior professor and head in the Department of Pulmonary and Critical Care Medicine in the University of Health Sciences, Rohtak. He's also the alumnus of PGIMA Chandigarh, Rohtak, and PGIMS Rohtak. He was awarded the prestigious Commonwealth Academic Staff Fellowship in Pulmonology in 2009 and is also the recipient of the Hansraj Nair Memorial Award of the ISCCM. Dr. Professor Chaudhary is a pioneer in the field of telemedicine in Haryana, and the first center in telemedicine in the state was established in Rohtak under his leadership. This is something very relevant today because today everything is telemedicine and he has established it back then, and today it's the new normal. He has also established the first center of simulation for training of the medical students and also trainee doctors in critical care, medicine and bronchoscopy in PGIMS. He has authored several publications. He's also been on many podcasts and public awareness programs. We'll be talking a lot about this over the next few minutes as well. and he's been a proficient, prolific speaker, and he's been the speaker at many conferences as well. So, with this very brief introduction of both the speakers, I welcome both of you to the show to discuss about ISCCM more so in specific, because we have both the current president and the president elect, right? So, my question is to Dr. Dhruva first. For the audience who have joined in, we would like to understand what is it that ISCCM has to offer for the new joinees, and who are the ones who can actually join this society, and how can we benefit?
Good evening, Pavitra. Thank you very much for a very elaborate introduction of both of us. Indian Society of Critical Care Medicine, as you very rightly said, started in 1993 by a group of 6 to 7 people in Mumbai. And it has grown up, rather I would say exponential growth has taken place, especially during last 7 to 8 years. Because initially critical care used to be a part and parcel of either primarily of anesthesia, because it was a normal extension of whatever they were doing it. Later on, some amount of people from internal medicine or from respiratory medicine started joining it up. Now, when you look at it today, probably the thing which has brought front everything has been your COVID epidemic. Prior to that, we had the similar thing when the swine flu came. People do remember intensive care units when they go on ventilators, or when you feel or go into the field of trauma, or large extensive surgeries which have been taking place nowadays. Now, when you look at the critical care, as you rightly said, it's an interdisciplinary department. Dr. Deepak Govil has a primary training in anesthesia, and I'm primary training in internal medicine. So both are the different sides, but it's the twain which meet. So when you look at an intensive study, Indian Society of Critical Care Medicine, we have 5 core specialities we look forward to. Obviously, anesthesia, internal medicine, respiratory medicine. Similarly, we look at a general medicine also, emergency medicine. And then also you start looking some amount of people initially in the orthopedics or obstetrics and gynae, specific relevant they were looking at. Mm-hmm. So practically, if you ask me today, if I put medicine into emergency medicine, acute medicine, and critical care medicine, so our role starts whenever there is need and requirement of an organ support. So that's the primary job of an intensivist. Therefore, we can say it, we are physicians of acutely sick organs. That's what we look at it in a simple term. Now, what we can offer? We can offer you a platform where we can assure you a professional growth. We can assure you mentoring. We can assure you introduction to an outside world. We are now, with the last couple of years, and myself and Deepak working as a team, and earlier Subhal and a couple, they were there. We have been trying to create more and more academic platforms where we can realize that people spend minimum and learn the more, because that's important, and that's the motto also. And the area which we have now started moving into is a clinical research, and we intend to put whatever we are having it and put it into research. And this year, before I demit my office in October and hand over to Deepak, I have a dream to start something in an intensive care. The youngsters are extremely tech savvy. Therefore, and the government of India is putting Swavlambi Bharat, or basically startups where we need to have it and make in India process, made in India. So I think we need to contribute. And my wish and my dream is to create a force of youngsters who are technocrat, and it becomes a center of meeting people, not only from medicine, but from technology and from other areas, allied areas like bioinformatics and other things, so that we create a pool which can act as a think tank and guide the industry, guide the people and the professionals who are joining the industry. And secondly, my cherished dream also is to be advocacy of public safety, patient safety. Because I think that is very important. That advocacy has been taken up in various fora at different places, but I think in an organized way, it is not there. So that is what we look forward to. And also, like our earlier colleagues and predecessors have taken ICSM to ISCCM to different portions, but I think we need to part more actively and lobby for the policies which are going to be beneficial, and one of them you can see is an end of life issue, Aruna Shanbake. So if you see it, it's a 360 view which people get, and the youngsters have it, but additionally, they also will be taught, or they also will be shown the path of being socially responsive, and how can we practice in this institution, and how can we participate in health economics and policy. Very ambitious, but I think that's what we can give it to you.
So I was just about to say it's a very ambitious goal, especially with the kind of pool that we have in India. It's not a very small group. It's a huge pool of doctors, and also since it's interdisciplinary, it's just not just diabetes. It's not just one pool. You're targeting a big mass of doctors. It's a fairly ambitious goal, but I think it's amazing if we get there. Nothing like it. I think now that Dr. Dhruva has mentioned about empowering doctors with technology, I'd like to understand from Dr. Deepak Govill, what is your take, especially now that you've seen over the last few years how critical care medicine has evolved. I'd like to understand how much has technology impacted the way the current management is going on, especially in critical care, and how do you think the younger doctors should actually upskill themselves to match the evolving technology and research?
So technology is always evolving, and if we don't imbibe that technology in our day-to-day practice, then there is a feeling that one has left behind. And it is not only the left behind, the benefit of technology will not reach to the masses, because what we are doing is directly the patient care. Every critical care doctor is involved in the patient care. So if my knowledge and my technique are lacking behind, then there is a possibility that we are something missing in the patient care. So that is one aspect. Another aspect is, if you ask me which technology has made the change in this current era in last 2 decades, I would say in critical care it is the ultrasound, which has changed the way of management. As you rightly asked, that what technology has changed the management, the ultrasound has changed the way of treating the patient in ICU, be it initial management, be it ongoing management or monitoring of the patient, and be it the procedures. So ultrasound has changed. Another aspect which is not directly into the patient in critical care is the microbiology advancement. So the the identification and you mean to say the identification of the bacteria and virus and different causative pathogen has become very fast and rapid, and this also helps in the contributing the patient care. As far as the technology is there, technology is coming right, left and right centers. So we have to see which technology is useful, which is going to stay for a while, and which is not that useful. And side by side, we have to see the cost effectiveness of that technology. In India, we cannot afford that technology which is not available to masses. So it has to be there in 1 or 2 centers, which are the lead centers, or where we can show that technology. But again, the technology should be so affordable that it can reach to millions and millions of the people. Otherwise, it's not going to work. We are not sitting in the Western world where the hospitals are too many and the patients are too less. We are having different scenario where the hospitals are less and patients are too many. So we have to pick and choose.